Hello, everyone. My name is Thibo Degeeter, and I'm a last year medical student at the University of Ghent. I will give a presentation about my thesis that I've written together with my partner Birgit de May and Professor Coppens as promoter. We did a prospective audit on fasting status of elective ambulatory surgery patients correlating to gastric ultrasound at the surgical daycare hospital of UZ Ghent. First of all, we established a questionnaire on the basis of a literature study. Patients were questioned by us students, and afterwards we performed a gastric ultrasound. Apart from general information, patients were asked for how long they were fasting for solid foods and their last meal, and liquids and their last drink. These are also the endpoints of the study. Besides this information, patients were also asked if they had any conditions that could have an influence on a delayed gastric emptying. The gastric ultrasound is to check the fasting status of the stomach. The purpose of the study was mainly to examine any problems in the spreading of the information about the fasting guidelines and to locate those exactly to eventually give a better preoperative policy. The preoperative guidelines know their own history. An important moment in the history dates in the 60s, 70s, where nil per us from midnight was introduced. This guideline is still used up till now. It was until 1980 that this guideline was questioned and studies were performed with lesser fasting times. The most recent guidelines date from 2009 from the European Society of Anesthesiology and are the 642 rule. 6 hours fasting for solid foods, and solid foods are defined as a normal meal with the exception of fried, high on fat meals or red meat. 4 hours fasting for breast or formula milk, 2 hours fasting for clear fluids. The definition of clear fluids has expanded from other to coffee or tea with a maximum of 1/5 of milk, pulp-free juices, carbonized drinks, and the carbohydrated drinks. The reason for these preoperative fasting guidelines is to reduce the risk on aspiration pneumonia. In the literature, patients fast too long in comparison with the guidelines. Fasting too long has complications on pre, per, and postoperative stages. Bedside ultrasonography is easy to perform to evaluate the fasting status of the stomach. There are 3 gradations that can quickly be examined. Grade 0 is an empty stomach in supine position and right lateral decubitus. Grade 1 is an empty stomach in supine position but contents on sonography and right lateral decubitus. And grade 2, you can see contents in both positions. A grade 2 has a higher risk on aspiration pneumonia. Via the cross-sectional area of the antrum of the stomach, the volume can be calculated. The formula is not for pregnant women or patients with a BMI above 40 kilograms square meters. Also, children have a different formula. If there are any reasons to believe there is a higher risk on aspiration pneumonia, there are certain techniques to reduce the risk. Here you can see an ultrasound of an empty stomach with the bullseye phenomenon. And the second ultrasound shows a full stomach with shades of the contents. Mean fasting times for solid foods are 13 hours and 29 minutes. Mean fasting times for fluids are 9 hours and 51 minutes. These exceed the guidelines enormously. Those extended times of fasting have different kinds of disadvantages for the patients. When we look to the percentage of patients that knows the correct guidelines, you see this is only 48% of the patients. 50% of the patients knew the nil per us from midnight, and only 2% of the patients didn't know any guidelines. Patients who knew the guidelines have significantly fasted less longer for fluids. For solid foods, there is no difference. An explanation for this will be discussed later. Via the questionnaire, patients were also asked how they were informed about the preoperative fasting guidelines. When we look at these results, you can see that the secretariat is the most important source for the patient. The secretariat calls the patients the workday before their surgery to give them the time of the operation and the guidelines. When we look at the different fasting times for solid foods and fluids between the sources, we see extrema in each group. Here you can also see that the maximum time of fasting for solid foods is 20 hours and 30 minutes, and for fluids it's 26 hours and 50 minutes. In this table, we can see on the one hand the last meal and on the other hand the last drink. Only for snacks there were significant smaller CSAs in comparison with the other meals. The mean fasting time in comparison with the type of meal shows no significant difference. Between the type of drink and the CSA, there was also no significant difference found. There is a significant difference in fasting time for patients who drank water versus all others. Patients who drank water have fasted less longer. As previously said, patients fast far too long. Some possible explanations could be the fact that only 48% of the patients knew the correct guidelines. Some patients are also afraid to drink or eat something before the surgery due to possible complications. This is regrettable since fasting too long has its discomfort. The 642 guidelines are based on the hour of registration to the hospital and not on the hour of the surgery. There is often an hour between registration and the surgery. When we look at the mean fasting intervals, we can conclude there is definitely room for improvement. Only this is practically not always possible. When a patient is scheduled for 8 hours on the operation program, they would be allowed to eat until 2 hours during the night. But we all know most patients are asleep at the time. But patients who are scheduled in the afternoon would be allowed to eat breakfast or even lunch. Apart from solid foods, there is also room for improvement for fluids. Actually, almost every patient is allowed to drink when they wake up before the surgery. A possible solution to strive for better compliance as for the preoperative fasting guidelines is within the Secretariat, since they are the most important source for the patients, but this requires a strict operation schedule. On the practical side, it is mostly for fluids that there is a possibility for improvement. Carbohydrated fluids have been proven to have a positive impact on the metabolic state of the patient. So it is advised to recommend these drinks 2 hours before surgery. Another possibility is to offer the drinks to the patients during admission to the hospital. Recent studies have proved it is safe to drink up until 1 hour before surgery. In this way, some discomforts and/or complications can be avoided and post-operative recovery can be fostered. As a last point, I would like to discuss the ultrasound. Ultrasound is underrated for its use in this setting. When patients say they have eaten or drinking something within the 6 or 2 hours, the operation is postponed. The anesthesiologist can easily perform an exam to evaluate the risk of aspiration pneumonia. So it could be used in emergencies or when there would be any doubt. It is easy to learn and it's non-invasive for the patients. I would like to thank you for your attention, also on behalf of my thesis partner Birgit de May.